Whoa, hey everyone, happy Saturday. Hope everyone's ready to do some posture. All right. Let's get to it. Posture is super, super important. So first though, I'm super excited to mention this, but we're starting memberships, yeah. Memberships for the Instructor Brooks campus. Whoops, there we go. So you can join our channel. You're going to get a lot more stuff here. We're trying to do this to grow things, to get you more of what you need and more of what you want. So we're currently going to be offering two different types of memberships. One is just a supporter. Hey, if you're able to support or want to support what we're doing because you find it helpful or to help pay it forward to other students in the future, then please feel free to be a supporter for $2.99 a month. And then we got the student membership for $9.99 a month. And that's going to give you access to exclusive members-only videos, exclusive members-only live stream, access to polls so that you can tell us what you're most interested in so we can make the videos you want and that you need to help you through your journey, through your PTA program. So super, super pumped about this. How do you join? Well, underneath all our videos, you're going to see, whoops, let me get the marker out here. You're going to see the join button. Click that and give you a little more detail about the memberships. There you go. Super pumped. What we're going to do with this money is we're going to grow this channel. We're going to give you more content. We're going to give you more stuff. And it'll help us take care of Mallow too. During the live stream, if you want, feel free to get a super sticker or super chat if you want to, show any appreciation or support for what we're doing today. Feel free to do that. It's kind of cool. And don't forget, success stories, share those with me. So I do this for every live stream, but there are plenty of people who have told me how watching the videos or watching the live stream helped them pass the boards, which honestly, right, that's what we're all trying to do. That's how we get our license. So many different success stories. We got the Netherlands. Look at all these. This is my favorite screenshot to get. Passed the boards. Boom. Boom. Love it, love it, love it. A lot of people passing the boards this last time it was done. So let's move on to the lesson that you're here for. Clinical view of posture. As the great Instructor Brooks once said, if you don't improve posture, then you haven't fixed anything. So you have to fix the posture. If the posture is causing the problem, anything you do outside of that might be fine for the short term. The problems will always come back if you don't fix posture. And as always, our study tip, one-on-one tutoring is a great way to make your studying more efficient and reduce just studying random stuff. Find the person who knows, whether it's your instructor or me, who can help you one-on-one to keep you focused so you study stuff and you're not wasting time. Objectives today. Well, we're going to know some basic vocabulary. As always, you got to know vocab. So if there are any words that I use that you just don't understand the definition, feel free, put it in the chat or comment and I'll get to you ASAP. Whoops. Also, we're going to correctly identify the landmarks for assessing posture. That's crucial, especially when we get into our documentation. Understanding what you can see in different views. This is probably one of the biggest things just in the classroom that I see with students is they miss questions or they say they see things analyzing posture, but technically they're not doing it from the correct view. And we'll make sure that's clear. I want to make sure that we understand what is tight and what's elongated with poor postures. That's a lot of your test questions you get early on. Deals with if this posture is presented in a patient, which muscles are tight, which muscles are elongated, what structures are compressed, what structures are not, all that kind of stuff. So we'll talk about some of that. We'll also give you some examples of proper documentation, which I want to give a shout out to one of my current students who is in the clinic, just got back from her first rotation, and I worked pretty hard on SOAP notes, and she got company recognition at your company, Christy, at your company for her documentation. So I like that little testimonial there. And we're going to answer some test questions correctly. That's the hope. So there's our objectives. Our sources, the physical rehab book, the old O'Sullivan book, and then just, some other anecdotal things here. So when we get to posture, there are lots of ways to think and look at posture. What is ideal posture? I would say, personally, I don't know. It's the posture that doesn't cause pain. That's what works for you. So we're going to look at what ideal posture is with this plumb line in a minute, but I think we'd have some discussions about how forcing postures onto people or forcing what we should have is not the best clinical decision, but we're looking at academics right now so we can answer test questions correctly. So let's take a look at this lateral view. I want us to understand that with the lateral view, we have two sides. So we should have a left and right lateral view when you do a full assessment. So you look at this lady here, the only knee or the only side of her body you really should be viewing is the left side. But a lot of times in your classes, they just say lateral view, front, posterior view. Just make sure it's a left and right. So let's look at the spots for major landmarks. Now your plumb line is going to start, and this is one of the things students, and honestly I've not found clarity even in O'Sullivan, so we're going to say it always starts at the bottom. And it's just anterior, just anterior to the ankle, just anterior to the malleolus. That's where it should be. So always line that up first, okay? Then we're going to work our way up. And the plumb line should fall just anterior to the knee. So it literally kind of splits the difference between the patella and the knee and the femur. That's technically where it's supposed to be. Then as you move up to the hip, it should be just posterior. So we have just anterior to the malleolus. Then we have just anterior to the axis of rotation at the knee. Just posterior running through that greater trochanter. Ideally, and this is where it gets a little more tricky, running through S2. And then we have up in the thoracic spine, if you couldn't see if the arm's there, obviously you won't be able to see that easy, but through T7. Up straight through the shoulder, right through that shoulder, and then the external auditory meatus. External auditory meatus of the ear. That is considered ideal posture. For whatever that means, as we just talked about. So that's the normal. So what are the deviations we can see in the lateral view? So we'll run through a few. Genu recurvatum, that's one. So that's going to be your hyperextension of the knee. Also flex knees. Someone has a little bit of a crouched gait where their knees are flexed a little bit. You'll see that from the side. Pelvic tilts. Is it anteriorly tilted, posteriorly tilted? Increased or reduced lordosis. A lot of that's going to be based on the pelvic tilt. Flexed or extended hips. And what you'll note, what you should start to think about is how would you document these things off the plumb line? And again, we'll talk about that towards the end. You can also see kyphosis of the thoracic spine, protraction of the scapula, rotation of the shoulder, cervical protraction or retraction, and capital flexion and extension. So there is a lot you can see from the side. Remember, there's two sides though. Make sure you check that right and that left side. Now we have our posterior and anterior view. These views are pretty simple because everything needs to just be symmetrical. The nipple line needs to be even. The iliac crest of the pelvis need to be even. If you look from the back, the posterior, the gluteal folds, the scapula, everything just needs to line up across here. Pretty easy when we're looking at the anterior and posterior view. So let's take a look at what kind of deviations we could see. Sorry, I got that covered up here. Let me move it. Appreciate your patience. There, now we can see. So, starting at the ankle and moving our way up. And I recommend always pick the same spot and go. So if you want to start at the top and go down, fine. I think it makes more sense to start at the bottom and go up. That's what I would do, start at the foundation. So at the ankle and the foot, what are we going to see? We can see excessive pronation and supination. We can see the valgus and varus at the knee. And if you're like, I don't know what these things are, that's totally fine. That's where we need to dive in a little deeper, and I have plenty of videos explaining this. See if the pelvis is elevated Is one side, let's say if we're looking at this, is this a little bit higher? Are we stuck in a little hip hike here? Is the quadratus lumborum a little tight for that person? We can also in the posterior view specifically see scoliosis. Again, we can see protraction of the scapula. If this scapula here is coming around a little bit. Cervical lateral flexion. Is the head tilted to one side a little more than the other? And of course, in the anterior view, you can also see some jaw deviations as well. So there's a lot we can see from those as well. Make sure we look at the front and the back. All right. Oh, nice kitty in a box. Megan, I love that. It's awesome. Okay, so we are going to go to the lab here in just a sec. We'll have to take a quick time out as we switch some camera stuff around. But what I'm going to cover, we're going to analyze some very common postural deviations. We're going to look at increased lordosis, flat back, and increased kyphosis with forward head posture. I'm going to talk about what's tight, what's elongated, what's stressed, and I'll mention a few super basic exercises that you can do to try to correct those. Also, another advertisement here for you. If you want to just buy us a coffee to help energize us on these Saturday mornings, feel free to go to Buy Me a Coffee, Instructor Brooks, boom, and buy us a coffee or a latte or whatever caffeinated beverage you would like to buy us. So during this time, if you're following, hop over on to Discord. I don't think we have that issue to worry about at the moment. But let me put in the chat the Discord link that you can sign up for raffling off a free muscle anatomy study strategy. Whoops. All right, you should be able to hop in there. If you want to during the break, get up, stretch around a little bit. I mean, that was a good 12 hard minutes of information. So make sure you have time to process. Whoops, not that one. So, hey, I'll see you guys in a few. You can. Well, whatever's on there, we should be. Yeah, if Megan's seeing it there, we're good. Hey guys, we're back. Here's the old live feed in the lab. All right. It's live. Whoa, we blew it up. We blew it up. All right, we're back. Megan, can you hear me? Megan. Awesome. All right, we're bringing Brandon back over here. If you remember him from the balance. What's up, Brandon? All right, so we're going to take a look at some different postural deviations. Might be easier if we come over this way then, I guess, for Christy. So Brandon's going to pop back this way. The first one we're going to look at here is going to be what I pick, increased lordosis. So we're going to look at increased lordosis first. So with increased lordosis of the spine, we need to think anytime something's happening with the spine, what's happening with the pelvis as well. So this person with increased lordosis is probably going to have, if it's increased lordotic posture, an anterior pelvic tilt. So we got to think about what's going to be tight when the hip is anteriorly tilted. So when the hip is anteriorly tilted, it's actually in hip flexion. So all of your hip flexors are going to be tight. Iliopsoas, your rectus femoris will be a little tight at the proximal end. So those are going to be tight. Also, if something's tight, if we got something working in the front, we got to have something working in the back. His low back extensors, those erector spinae, lats, are also going to be tight. Now what's going to be elongated with the hip portion is going to be your rectus abdominis. That pubis is now moved inferior with that anterior tilt, so the rectus abdominis is being stretched out. And then also in the back, since the ischial tubes are up, now you're going to have elongated hamstrings, okay? So those muscles are going to be affected by this posture and position. So we're going to need to strengthen what's short. You might need to strengthen what's elongated as well, but we need to understand at least what to stretch and what muscles are involved. So let's see. This would be a good thing, like if someone was had this posture, say laying over an exercise ball, just to try to encourage more thoracolumbar flexion. Plus then strengthening of those hams to try to work on that posterior pelvic tilt would be a pretty good idea. Let's see. The next one was flat back, the exact opposite of increased lordosis. We are going to have flexion now of the lumbar spine. So the hip is going to be posteriorly tilted. So what's involved in a posterior tilt? Well, now the hamstrings are going to be shorter because the ischial tube is moved inferior. The hamstrings are going to be tight. And then what's going to be tight in the front? The rectus abdominis, because those are the muscles that work together as a what? Type it in the comment when more than one muscle, so two or more muscles, create a rotational component. Write it in the comments because I'm not going to tell you the answer. But those muscles work together to do that. Now, what's going to be elongated? The opposite of last time. The erector spinae are going to be elongated and the hip flexors are going to be elongated. So how would we work on stretching this? Well, maybe you take that same Swiss ball and now you lay supine over it to try to encourage some lumbar extension to try to get that going, okay? And then what was the third one I was going to increased kyphosis with forward head posture. All right. So with this, there's a lot going on. And I know this might look exaggerating, maybe for someone standing, but I'll tell you right now, you look at someone sitting at a desk, that's what they look, be like, freeze and stand right up. Yeah. Here we go. Perfect. It'd be like sitting, working on his computer, maybe even doing some soap note documentation. So with this posture here, you're going to see obviously increased kyphosis. And something else you should be considering is when you have the spine in these extreme situations, what part of the disc is being compressed and what part is not being compressed. So with this kyphosis, we have a lot of pressure on the anterior portion of the disc. So it's going to start to push it posteriorly. And that's where you start to get, with any type of flexion of the spine, those posterior protrusions, okay, or herniations. Now, so we have the increased flexion or increased kyphosis of the thoracic spine. So all those erector spinae are getting overstretched and weak. Also with this too, you're going to have that protraction of the scapula. So with this protraction, those rhomboids, and middle traps, very elongated. So if they're elongated because the scapula is protracted, what muscle do you think is going to be tight in the scapula? And that's going to be your serratus anterior. So we might need to stretch that, talk about some manual techniques someday to help try to release some of that serratus anterior. Also with this kyphosis, look at the front. He's going to be very flexed. So those abs up here are going to be pretty tight. So if this is being elongated, those abs are going to be tight. Now, as we work our way up, most students can get this right. Sometimes the scapula kind of gets them. Now we get to the cervical spine. The cervical spine is, I would say it's protracted. I wouldn't say flexed as much. Flexion, protraction is a combination of cervical flexion plus the actual protraction. So we have that protraction occurring in the cervical spine or cervical flexion, whatever, you can say either one. But here's the kicker, here's the key, is that right at C1, at the capital joint, you have extension. And this is where a lot of test questions, if they ask about what's going to be tight here, the traps that are running up here are going to be elongated up until they reach the skull. So remember, the traps are going to insert at the base of the skull. So that's at extension. Why is it at extension here but flexion here? Well, if Brandon just keeps, if he doesn't look straight and just kind of looks where his neck is going, he'd be looking at the ground all the time. So our compensation for this posture that's bad all the way here is to extend right at the capital so that now he can look forward. That's why this classic at the computer, if you don't have this up, this is falling down, but so you're not looking at the keyboard, you're looking up at the screen. This is what happens. So those suboccipitals, exactly, those suboccipitals, the upper traps, at this portion are just getting super compressed, super tight, and that leads to a lot of problems here. Plus, then people feel tension through here. Why do you think they feel tension here? Those muscles are elongated, so they're trying to hold things up, not in the optimal position. So that's our forward head posture up to the neck here. Then we look at the shoulder. So we talked about the protraction, but also a lot of times you're going to get that shoulder internally rotated then with that protraction. So all of our internal rotators, subscap, pec major, totally going to be tight with this. Our force couple, when two muscles that do opposite things work to create rotation, force couple. Awesome job, Jesse. That's what I'm talking about. Some basic kinesiology terminology. See, you got to know the vocab. All right. We talked about that. Some basic exercise. Thanks a ton, Brandon. We are going to run back to the computer desk, and I'm going to go over some documentation and give you some test level questions, and then we're done. That's what I'm talking about. A nice, quick Saturday. Enjoy the tunes. All right. We are back. So let's get into this documentation. Let's get on with our wonderful Saturday. So documentation example. Let's look at the O first. So this would be way, way, way more detailed than this. I'm just giving you some examples here, though. So the plumb line is an observational assessment. So you good? Okay, awesome. So make sure that you are putting this under your observation data collection. So usually your PT is going to have you do that like data collections under therapeutic exercise billing 97110. Don't feel like you have to memorize that. That's like the only one I have memorized. But that's what it would be. So I just wanted to show you that. So what I would do is document lateral view, left side. Remember, the lateral views, we got two. We got slight genu recurvatum of the left knee. I'm just making this up. Pretend that's what I saw. Then on the right side, I should check both, because is genu recurvatum a problem? Depends. If someone does not have pain, should we fix it? That is always the philosophical question in physical therapy. Do we fix the problems if they're not a problem? I don't think we should, personally, my opinion is we shouldn't force ideal, because ideal, again, is for what works for that individual. So if I saw genu recurvatum on the left knee, my actual biggest concern, if there isn't knee pain, is it the same on the other side? I really want some symmetry, or otherwise, then that might be a problem. And if she's got, or he's got genu recurvatum on the right knee, then they're symmetrical. We don't have a leg length discrepancy. That's why I'd want to check that out. Even if, say, they were having back pain, maybe it's because one knee has genu recurvatum, the other doesn't, causing a leg length discrepancy, thus leading to the back pain or the hip hike that you see. That's why I love posture, because there's so many things we can connect to that to see. We don't want to get stuck in this where we're just looking at where the pain is or where the injury is. We need to look head to toe, because that could really tell us what's the problem. Frontal view, you could see valgus. So maybe we got a little right knee valgus, which could also affect the leg length. And in the posterior view, I see some right foot pronation. So let's think about this. On this right leg, it has excessive pronation causing valgus of the knee and potentially some genu recurvatum. So this could be, totally just saying this as an example, what if this person is complaining of back pain, what if the back pain is because they're overpronated on the right, and we need to do some shoe supports, some arch supports to fix that, and that would then fix the back. If we just stay focused on the back, we may have missed this the whole time. And, you know, no offense to the PTs, but they got a lot going on. They're doing a ton on their evals. Sometimes things get missed. And as a PTA, you see the patient usually more often. So maybe this is something you catch and you can talk to the PT about and help that patient. So we have the objective. I didn't put in there the exercises we did to fix it, but just so you can see how we would do that. Here's the assessment. And this is what I've tried to work really hard with my students on that assessment. So I've highlighted some words that are good buzzwords that you should have in your assessment. So following treatment, the patient observed with decreased verbal cues for posture and verbalized reduced pain. So this right here, this decreased verbal cues for posture shows how effective your treatment was. Were you effective at doing what you wanted to do? Well, they have decreased pain and, sorry, gotta fix this. And they're taking less cues to fix their posture, which is always a huge thing. So that means they're able to self-correct. What was I going to say? Oh, so it says here the patient verbalized reduced pain. Where would you document that the pain was reduced? Like, where would you put their number? If it was 5 out of 10 when they first came in, they leave it's 2 out of 10. Where would you put that? Type it in the comment section real quick while I take a drink. Who knows? Who knows? Megan didn't hear it. The subjective. The subjective. Anything the patient says goes in the subjective. That's where we keep track of that information. Next sentence. Patient still presents with forward head posture and requires, so still presents and requires cues to correct postural deviation. So they're not fully autonomous when it comes to correcting their own posture. So still presents and requires shows why you're needed, shows why we need to continue some therapy, and shows how, even though they might be better, we're talking about the quality of their posture, so it still needs help. It's always good in the assessment to mention goals. Are we on track? Patient is on track to meet short-term goal number 3. I don't know what short-term goal 3 is, but made it up. But putting a specific goal in there like that is fantastic. And patient continues to need skilled therapy. One thing people want to see is what's the reason for skilled therapy? Why is it still needed? Well, if you put in the phrase continues to need skilled therapy, whatever you say after that is why they need to come in for their next visit. to meet the goals for pain and function. Boom, there you go. That is super basic, super simple. We could definitely build on that, but that is a starter for why they still need skilled therapy. And then we get to that plan. It's always nice if you can mention something that you might want to talk to the PT about. So contact the PT to see if there's need for a shoe orthotic to reduce right ankle pronation, like I talked about earlier that I noticed in my lateral view assessment on the right. Okay, here we go. Test questions. Let's see. Can we answer these? This is what it's all about. So the patient presents with increased lordotic posture. The PTA is trying to recall which of the following would be most likely to have tightness. I'll put the poll question up here. Whoops. Feel free to answer that poll. Let's see which one of you guys gets it. Hopefully all of you. It'll take like 10 seconds. What? Oh, that's all right, Maxie. We got some dissension here. We got C's and B's. All right, we're going to end this poll. C's and B's. Let's see. I didn't write down the answer, so I'm going to read the question again. The patient presents with increased lordotic posture. So what type of tilt? Anterior pelvic tilt. PT is trying to recall which of the following. So if it's an anterior pelvic tilt, the hip flexors would be tight, so the hip extensors are not going to be tight. The thoracolumbar extenders, I think I remember Rick saying the erector spinae. With increased lordosis, the low back is an extension, so there's erector spinae, so the thoracolumbar extensors are going to be tight because the flexors are going to be elongated as well, as are the hamstrings, which are also hip extensors. So the thoracolumbar extensors. So your erector spinae lats are going to be tight. All right. Next question. It's the last one. It's the only one. These are the types of questions that you see on exams and the boards that are brutal because, number one, read everything correctly. Number two, can you envision it? That's the hard part with some of these. So good luck on this one. I'll put a poll up. You may not love any of the answers, but you got to pick the best. So when we're taking these tests, taking the boards, you pick the best, even if they all suck. Pick the best of the sucky ones. All right, I'm going to end the poll here. We got everyone so far saying D, so let's see if that's right. So the patient presents with flat back posture. Which of the following would be the most appropriate treatment for the patient with a goal to improve posture? So when they ask questions like this, I mean, it's brutal. So can we envision these treatments? So if someone has flat back, before I even look at these options, the first thing I'm going to think of are some stretches. So with flat back posture, we have a posterior pelvic tilt. So our hamstrings are going to be tight. What else? Rectus abdominis. So those two are going to be tight. So I'm leaving that off to the side. So if I see anything that looks like treatment that's going to be helping stretch those, I'm picking it. However, if there's strengthening or other things, that might throw me off. But I give myself, you know, a running head start here. So position the patient in side lying and adductus superior leg. No, because you know what this is? That is stretching of the glute medius or the IT band or something. It's stretching a abductor. And I never talked about abduction with the situations today, so that's not right. So let's go to position the patient in supine. Maintain knee extension of either leg while flexing the same hip. What's that going to do? Well, that sounds to me like the passive insufficiency position for the hamstrings, which means we'd be stretching them. So I like B. I want to see if there's other answers for the best, though. Okay, so I have a connection. I'm loving this right now. I'm loving B. Position the patient prone over the thorax ball. If we position them prone, I talked about that, but if I position them prone, what would that do to the low back? It'll flex it. They're already in flexion, so it cannot be C. Now let's look at D. This is the one that people thought was the right answer. Position the patient in standing. Have them, not then, have them reach behind and grab the foot of a flexed knee while trying to extend the hip. This would be an example of stretching the rectus femoris. So is the rectus femoris going to be tight in this situation? Absolutely not. It's the rectus abdominis. So the correct answer is B. Oh, I hate those questions, but it's B. That's the correct answer because it's the only one that shows treatment that's stretching the hamstrings that's connected to any muscle involved with this situation. That is tough, but that's what we got to do. That's what we got to do. So if you didn't get it right on your own, honestly, I tell you what, studying and understanding the pelvic tilts and how that connects to low back posture can go a long way into answering a lot of these questions. Hey, we are done. Don't forget, there was the giveaway on Discord. Hey, but I have my, oh, nice. I have my muscle anatomy study strategy that I'm giving away for free. If you don't know the muscles, you don't know the motions, it really doesn't matter. You're building everything on a foundation of sand if you don't have the foundation of muscle anatomy. So check that out. Get into Discord if you haven't already. Links in the chat for the giveaway. Now, I'm really excited about what we're about to talk about here. Upcoming. So our next live streams, we're going to really bring it up a notch. So the foundations of gait, it's going to be a nice, basic sit down with some coffee session. We'll show you some basic, all 8 events of the gait cycle. So your heel strike all the way through terminal swing. I love it. You have to know the normal. I love talking about this. So we're going to talk about that. And then on the 14th, we're going to talk about gait deviations. Probably my most popular video on just the public random videos on YouTube are gait deviations. So we're going to talk about gait deviations. And then on May 21st, it will not be in the free live stream. This is for members only. We're going to get into way more in depth on basic treatments for gait and looking at test questions that talk about that. So if you want to know some basic things to do in the clinic to start treating different gait deviations, just very basic stuff, but stuff that sometimes I think we forget. We get too fancy. We forget about some basics. We're going to talk about that. That is a members only live feed. And even after it's recorded, no one's going to get to see it unless you are a member. So it's exclusive. So if you want to see that, become a member. Even if you become a member for 1 month, you only want to see gait and move out. That's what's great about memberships. You only have to have them for as long as you want or need them. So check it out. And then, as always, have an awesome day. Great job. Whether you showed up on Saturday live with me or you're watching this later, you are awesome. Have an awesome day. Spread that stuff forward. Peace out.